بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلاب الطب وطالبات الطب بالمملكة العربية السعودية وخارجها، أرحب فيكم في لقاء جديد من لقاءات برنامج أطباء من حولنا. أرحب فيكم أنا عهود عسيري، طبيبة امتياز خريجة جامعة الملك خالد، وفي استضافتنا الليلة الدكتور نعيم جواد، استشاري أمراض الكلى بمستشفى القوات المسلحة بالجنوب. ومعانا من الأعضاء عايشة الأسمري جامعة الملك خالد، بيان المنعم جامعة الملك فيصل، أحمد بوزيد جامعة الدمام، معانا كمان مدى. مرحب فيكم جميعا. حلقتنا اليوم بإذن الله راح تتكلم عن الهايبوناتريميا، وراح تتكلم عن الكوزز. 3 نقاط أساسية، أولها الكوزز أوف هايبوناتريميا، ثاني نقطة الابروش أوف هايبوناتريميا، الثالثة المانجمنت أوف هايبوناتريميا. مرحب فيك دكتور نعيم، تقدر تتفضل؟
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. شكرا جزيلا على استضافتي في هذا البرنامج. واليوم راح نتكلم عن الهايبوناتريميا وبشكل عام any sodium or electrolyte disorders بتكون دائما محط حيرة لدى جميع الأطباء والدكاترة والمتدربين، وأجين لازم الواحد go to review on it، لأنه دائما بيكون فيها شغلات updated مش بيكمس. فأرجو أن تكون هذه المحاضرة خفيفة ومفيدة عليكم، ونبدأ بسم الله الرحمن الرحيم. Okay, today we are talking about sodium disorders. First of all, when we speak about sodium disorders, we have to know that the basic sodium disorders is not sodium itself, it is about water disorders. So most of the discussions of the dynatremias, if it is hypo or hypernatremia, have expressed the relationship between sodium, potassium, and total body water in an abbreviated and conceptually simple form, which is in front of you. Sodium is total body sodium and potassium over total body water. A low serum sodium does not total sodium is or normal. There is excess in water in relative to sodium, and a high serum sodium in relative to sodium. What we have to know is that sodium is an extracellular fluid and potassium is an intracellular fluid. Put this in mind for the future slides coming. This is a simple diagram showing the relationship between sodium and water, where if you look at the hyponatremia, our talk today, when sodium is equal to water component in the cells, this is normal or normal sodium. If the sodium is less than the water content, this is hypovolemic hyponatremia. If the sodium and water are almost the same, this is euvolemic hyponatremia. And if sodium is normal but there is water, more excess in water, this is called hypervolemic hyponatremia. This will show you that we are not talking about sodium is increased or decreased. This shows you the relative content of sodium in relative to water. So the disorder is from the water, whether it is high, normal, or low. Have two terms that we should talk about is osmolality and tonicity. These are two words used very oftenly in sodium disorders. Osmolality is the total solute concentration in a fluid compartment. Tonicity is the combined ability of solutes to produce osmotic drive force that causes water to move from one compartment to another. To make it easy, you have to know that osmolarity is the measure of solute concentration defined as the number of osmoles of solute per liter. That's why the unit is osmol per liter. Osmolality with an L is the measure of osmoles per kilograms of the solute as osmolarity per kg. Again, osmolarity with an R, osmolarity per liter, osmolarity with an L is per kg. However, if the concentrations of the solute is very low, osmolarity and osmolarity are considered equivalent. For the time being, not to make the students confused, we will say that osmolarity and osmolarity are the same. About physiology, serum sodium concentration and serum osmolarity normally are maintained by stimulation of thirst, secretion of antidiuretic hormone, and renal handling of filtered sodium. This is a simple diagram where when the body has a water deficit, osmolarity will increase, arterial pressure will decrease, both of them will stimulate the thirst stimuli and will stimulate the antidiuretic hormone receptors, which in return will cause water reabsorption to increase and there will be increase in urine output. On contrary, when there is water excess hypervolemia, osmolality will decrease. This will block the antidiuretic hormone receptors and block the fat receptors, causing water reabsorption to decrease, and there will be increase in the urine output. This is in the normal physiological body. Again, if we talk about salt deficit, in this case, osmolality will decrease, the same as the previous slide. Antidiuretic hormone will decrease, and this will cause water decrease, causing the plasma volume and blood pressure to go low. This will stimulate then, which is excreted by the kidney. This will go from angiotensin to stimulating the aldosterone, the sodium reabsorption to increase, and will be salt and water excretion. This can in this area where I am this that will cause in the end of salt and water retention keep the patient in the euvolemic state. In salt excess, there is high osmolality. There will be increase in cause water retention, plasma volume and blood pressure is increasing, the pressure is increasing, and antidiuretic pressure is increasing, causing block of aldosterone. The high plasma volume will cause block. Then
نعتذر عن الانقطاع. دكتور نعيم.
نعم.
تفضل دكتور.
نكمل اللي قطعناه. Finish this slide. When is hyponatremia a concern? طبعا not every hyponatremia is really a problem, because as we go on we'll see that there are too many causes of hyponatremia. But any sodium level less than 120 or more than 155, this should be taken seriously without any hesitancy. Clinical feature depends on the rapidity of hyponatremia. Acute hyponatremia, when it occurs in less than 48 hours, and chronic hyponatremia occurs when it's more than 48 hours. Actually, if we talk about the acute, the only, or most of the time, the only way that we acute hyponatremia is when the patient is inpatient. You know his sodium levels, and within less than 48 hours, you notice that there is sudden drop of sodium. Otherwise, if the patient presents to you for the first time, for example, in ER, and you find his sodium is low, then you will assume that it is chronic hyponatremia, because there is no way to know that this was normal in before 48 hours. So, sodium more 124 will asymptomatic, malaria, nausea, and anorexia. Sodium less than 125 will have headaches, decreased level of consciousness, seizures, ataxia, psychosis, brainstem herniation, respiratory depression, or unfortunately death. And neurologic symptoms are secondary to the cerebral edema. Sometimes you will have these neurological symptoms without the severe hyponatremia. So even if you find a sort say of 130 or 105, and the patient presents to you with these neurological symptoms, then you have to act seriously. How to approach hyponatremia? This is a very simplified algorithm, and we will take it step by step as easy as possible. But we have what we call pseudo-hyponatremia. It is isotonic, where serum osmolarity is 280 to 295, which is the normal serum osmolarity in the body. The causes are paraproteinemias like multiple myeloma. Each increase of 10 grams of protein will cause sodium to go down 1 millimole per liter. So when you look at the labs, first of all, when you have a patient with hyponatremia, first of all, look at his protein level. If it is above the normal level, then you have to count each 10 grams will cause 1 millimole decrease in sodium. Then you have to look to his lipid profile. Hypertriglyceridemia will also cause hyponatremia, with a level of 4.6 grams increase will cause decrease of sodium 1 millimole. This results in a reduction in the fraction of plasma that is water and an artificially low sodium concentration. Now, why is it called pseudo-hyponatremia? Because actually the sodium level is normal in the serum, but due to other substances, proteins and triglycerides are increasing in the serum. The machine to read factitious number or an incorrect number, and it will show that is low, but actually it is normal in the serum. How do we correct this? By correcting the paraproteinemias, or the decreasing the triglycerides. We have what we call translocational hyponatremia. It happens in a hypertonic serum where serum osmolarity is more than 295. The number one cause is hyperglycemia. The use of methylglycerol and IgG preparations, which are used in neurological disease or immunological disease. What happens is any increase in blood glucose will cause the shift of water from intracellular to extracellular fluid. Why is this? So we can balance the osmolality and tonicity of the blood. Because if there is high blood sugar in the serum, okay, and this means there's high tonicity, and the tonicity in the cell is less than serum, so water will be driven from intracellular to extracellular to balance the osmolality, which will cause increase in intravascular volume, and by default the sodium level will decrease. There is what we call an osmolar graph. It is the difference between the measured and calculated osmolality. In it is absent, and in manual it is present. So when you have a patient with hyponatremia and you're suspecting translocation hyponatremia, calculating the osmolar graph will help you to know if it is from hyperglycemia or not. Mannitol usually will be present by history, or if the patient usually have any surgery, or especially brain surgery. How the glucose affects the sodium? 1.6 millimole decrease in sodium for each 100 milligrams increase in glucose. So if the 100 milligrams increase in glucose is if it is above 200. So every 100 milligrams above 200, you will calculate for each 100 1.6 decrease in sodium. But if the blood sugar is exceeding 400, which then there is a high risk for diabetic ketoacidosis, then for each 100 milligram per deciliter increase in glucose, there will be a decrease of 2.4 milliequivalent per liter decrease in sodium. So in patients with severe hyperglycemia, there will be also in return severe hypernatremia, which should be put into consideration. Now, talking about true hyponatremia, and this is the major talk where there is hypotonic serum and it is lower than where the osmolarity is less than 280 millismoles per kg. You have to check the urine osmolarity. If it is less than 100, then maybe the cause is excess water intake. If it is more than 100, then there is an impaired renal concentration ability. How does the extracellular volume? This is a very important approach to know and make an impression of what is the cause of the hyponatremia. So you have to first of all examine the GDP, blood pressure. Auscultation of the heart and lungs are not really in the first. You have to also check for the skin turgor if there is edema or not. Check for the urine output, body weight, hematocrit, and serum protein. So the GDP is decreased, then it is hypovolemia. If it is increased, it is hypervolemia. If there is an orthostatic drop, tachycardia, it is hypovolemia. If there is inspiratory crackles, or the blood pressure is normal, an S3 gallop rhythm, then it is hypovolemia. A decreased turgor and no edema in the lower limbs will mainly show that the patient is hypovolemic. And if there are there is lower limb edema and skin turgor is normal or increased, then the patient is hypovolemic. Decreased weight is always shooting for hypovolemia, and hematocrit, when it increases, this will show that the patient is dehydrated. Urine output is really variable in hypovolemia. Sometimes it is normal, sometimes it is increased, and sometimes it is decreased. So we cannot assess urine output really in hypovolemia, but the body weight is increased due to the increased extracellular volume, which is full of water, and hematocrit is decreased, and this is a cause of hypovolemia. When we talk about hypovolemic hyponatremia, the main cause is diuretics, and the main diuretics causing hyponatremia is thiazides. in exams, usually when the MCQs, you have an MCQ in the exam, and it will show you, for example, an elderly patient, hypertensive, taking drugs, presented to the primary physician with general weakness and sodium, let's say, for example, 120. What drug has caused this picture? It is always thiazides. Thiazides will always lose more salt than glucose, and the urine excreted is almost as normal saline. The reason for hyponatremia of sodium, the volume depletion helps in antidiuretic hormone release. Loop diuretics, for example, furosemide, Thiazides, it loses more water than thiazides, and the reason for hyponatremia is volume depletion resulting in antidiuretic hormone release. So if somebody asks you which diuretics will cause more hyponatremia, it is thiazides. Loops will cause hyponatremia in the long run, and it might also cause hypernatremia. Osmotic diuresis. What is osmosis? It is a material semi-permeable membrane that separates solutions of different concentrations. Diuresis is secretion of large amounts of osmotic diuresis is increased urination, certain substances in the kidney tubules, for example, glucose and mannitol, where these substances will cause hypertonicity, and by that osmotic diuresis will happen. So if we go back, how to differentiate between glucose and mannitol is by the osmolar gap. Osmolar gap is negative if the glucose is the cause, and it will be negative. Osmolar gap is negative if glucose and positive if mannitol. Adrenal insufficiency. This also causes hyponatremia. This will be due to increased antidiuretic hormone. Decreased cortisol will cause hypotension and decreased cardiac output, which will increase the antidiuretic hormone. And decreased aldosterone will cause salt breathing, and decreased volume will cause increased ADH. Another cause is salt losing nephropathy. It causes hypovolemic hyponatremia. The renal disorders that cause salt losing nephropathy is interstitial nephropathy, medullary cystic disease, polycystic kidney disease, partial urinary obstruction. Hypervolemic hyponatremia. It happens in states where congestive failure and cirrhosis are one of the major causes. As volume is increased, but the pressure sensed at the curve is very severely low, and due to decreased cardiac output in the congestive heart failure and peripheral vasodilation in cirrhosis. High ADH vary with the severity of the disease, which will cause hyponatremia. So even if you find your patient very edematous in the congestive heart failure and cirrhosis cases, the blood pressure sensed in the baroreceptors is low. This will cause the increase of antidiuretic hormones. So even if you find your patient high blood pressure, hypertensive, actually it is not sensed by the baroreceptors. In nephrotic syndrome, arterial underfilling as the low plasma oncotic pressure leads to plasma volume depletion. In renal failure, the relative ability to excrete water is maintained in patients with mild to moderate renal failure. Normonatremia is usually maintained in the absence of oliguria or advanced renal failure. In the later setting, the minimal urine osmolality rises as high as 200 to 250, despite appropriate suppression of antidiuretic hormone, and osmotic diuresis is induced by increased solute excretion per functioning nephron, is thought to be responsible for inability to dilute the urine. So to make it simple, so renal failure will cause hyponatremia to excrete because the kidney cannot dilute the urine. So that's why there will be urine sodium. There will be water retention more than sodium, and this will cause hyponatremia. In euvolemic hyponatremia, the main cause is syndrome of inappropriate ADH secretion. The causes are CNS, mass lesion, trauma, stroke, subarachnoid hemorrhage, any malignancies in the lung, and the cause is small cell carcinoma, which will cause secretion of ectopic antidiuretic hormone. It is also shown in bronchogenic carcinoma and pancreatic carcinoma. There are certain drugs that increase antidiuretic hormone activity in chest infection or tumor. Simply pneumonia can cause SIAD, and pituitary tumor, pain, and HIV can cause syndrome of inappropriate diuretic hormone release. The drugs that can cause high ADH activity are central stimulation of ADH release, like vincristine, cyclophosphamide, carbamazepine, which is given in epilepsies, SSRIs that are given in psychological disorders, painkillers. There are oxytocin, which are ADH-like agents. Oxytocin is given during labor, and desmopressin is given for the hematological disorder. Drugs that can promote actions of antidiuretic hormones in the kidneys are fluoropromide, methylxanthines, prostaglandins inhibitors, and carbamazepine. How to diagnose SIADH? First of all, before we go ahead, you have to know that SIADH is a diagnosis of exclusion. This is number one. Number two, always SIADH should have euvolemia. So if any patient has dehydration or overload, you cannot diagnose him as syndrome of inappropriate ADH secretion. So normal hepatic, renal, and cardiac functions should be there. There is no hepatic or renal or cardiac cause for the hyponatremia. Clinically, the patient should be euvolemic, normal thyroid, normal adrenal function. It will be hypotonic, and the urine osmolarity greater than 100 milliosmoles per kg. If your patient matches all this criteria, then this patient is having syndrome of inappropriate ADH secretion. Any of the following causes, if you find any of these diseases present, then you cannot diagnose him as syndrome of SIADH. There is what we call reset osmostat. Maybe it is a little bit hard for your level, but this is the downward setting of the osmostat. What happens is, in hypovolemic states, baroreceptors to ADH release superimposed on osmoreceptor function. Quadriplegia, effective volume depletion may result from venous pooling in the legs, psychosis, TB, and chronic malnutrition. So, in general, what happens is, in chronic diseases, okay, there will be a decrease in the ADH release in response to the hyponatremia. So, for example, if this patient, the ADH usually would be stimulated if the sodium is less than 135. For these chronic patients, the ADH will be stimulated if the sodium will be, for example, 125. So in this case, it is not really a dangerous hyponatremia. Maybe in hospital or in ER, we will just say that this is chronic hyponatremia and nothing to worry about. Just to pass this, one of the causes of hyponatremia is hypothyroidism. Actually, the mechanism is really not well understood, but it is inability to maximally suppress the antidiuretic hormone, mostly due to decreased cardiac output. The release of ADH via cardiac sinus baroreceptors are stimulated. When hypothyroidism and GFR, the low GFR are combined, there is decreased free water excretion by diminishing water delivery to the diluting segments. Retention of the injected water and erosion in the plasma sodium is concentrated by dilution. In some cases of renal failure, if you correct the hypothyroidism in a good number of patients, the GFR will improve. This is a little bit so I will okay. Treatment of hyponatremia. This is the adaptive response. In the first, this diagram shows the adaptive response, which is very important in treatment of hyponatremia. In the beginning of our talk, we said that hyponatremia has acute and chronic types. Acute if it occurs less than 48 hours, and chronic if it occurs more than 48 hours. Actually, the treatment differs between acute and chronic, but this is a very complicated, dangerous step which we have to understand very. That's why we in brief about the adaptive response. So, in the state of decrease extracellular fluid osmolarity, the water will enter the cells. If you follow the mouse, this is the normal brain. Immediate effect of hypotonic states, what will happen is water will be absorbed into the brain cells, where there will be then increase in the intracellular fluids, which will cause edema. Okay, then by the increase of intracranial pressure caused by the water gain, this will cause neurological symptoms. So volume regulatory adaptation occurs in 1 to 3 hours, where fluid enters the CSF and shunted into the systemic circulation. Okay, enters into the systemic circulation and will cause decrease in the cerebral cellular fluid. The brain loses cellular potassium and organic.
أيوة دكتور نعيم، تقدر تواصل.
عفوا دكتور، بس لأن المايك مو مشغل.
Now, okay.
أيوة كذا تمام.
لو we are treating acute hyponatremia, the main problem is cerebral. You have to avoid cerebral. The risk of delay therapy is great than the potential risk of poor rapid correction. When we are talking about the rate of correction, it differs between acute and chronic hyponatremia. Correction is usually for the symptomatic patients is hypertonic saline, which contains 3% of sodium, and the sodium level should not increase more than 10 to 12 milliequivalent in the first 24 hours, and in other literature they say no more than 18 milliequivalent in the first 48 hours. So if the sodium is less than 110, develops more slowly, less severe neurological symptoms like fatigue and dizziness. They do not require aggressive approach. The initial therapy is 1 milliequivalent in the first 3 hours. Methods of rising of sodium is restricting. First of all, in every patient, when you are consulted or seeing your patient with hyponatremia, the first thing is restricting water intake. Always you say keep the patient MPO or restrict his fluids to, for example, 1 liter per day. And then administration of and as a new treatment, the vasopressin receptors antagonists. Water restrictions are mostly useful in edematous states, SIDH, in primary polydipsia, and advanced renal failure. Hyponatremia develops gradually in these settings and is rarely symptomatic. Restrictions to 50 to 60% daily food requirement and achieve a goal of a negative water balance. And if you put your patient into negative balance, this will be more helpful for the patient if it was in negative state. Sodium chloride administration. There are several types of saline to be administered in different cases of hyponatremia, but in general, hypertonic saline, which is 2%, is used for the symptomatic hyponatremia. Isotonic saline hits the hyponatremia mechanisms where one sodium it increases the sodium by 1 milliequivalent for every liter. And volume retention removes the stimulus to ADH release, allowing the excess water to be excreted. Sodium return toward normal. There is one point when you are treating hyponatremia. If the patient has, by coincidence, hypokalemia, usually we go for treatment with potassium chloride additive to the sodium chloride. What you have to know is that each potassium you are giving to the patient will increase his sodium by 1. So 1 milliequivalent potassium will increase the sodium by 1 milliequivalent. This has to be put into consideration for treating hyponatremia. For example, sodium chloride plus potassium chloride, you have to calculate it well. In treatment of ADH, the main issue is water restriction, and the isotonic line has a limited. Most of the time, this is corrected by restriction, and you use a loop diuretic where more water excretion will happen more than sodium by loop diuretics. There is a drug called lithium, and this is to use diminish
دكتور نعيم، لساتك معنا؟
أيوة معكم سامعوني؟
أيوة
ألو؟
الحين سامعينك. أيوة سامعينك يا دكتور.
أوكي.
تفضل.
These are the sodium concentrations that are present in the IV fluids, where 3% normal saline has a sodium of 500 milligrams. The normal saline is 0.9% sodium chloride, and it contains 154 milliequivalent of sodium. Ringer lactate, which is the preferable fluids used by the surgeons because it helps in decreasing acidosis during operation. It causes 130 milliequivalent. The half saline, which is 0.45, has 77, and the dextrose water is 0. This, if you know how much sodium is present in each fluid, this will help you in correcting the sodium in a very safe way, avoiding the complications. So here is an example calculation where a 76-year-old male, 75 kg, with a serum sodium of 108 millimole. So the change in serum sodium per liter, what we are aiming for is this is the formula that we use to know how much serum sodium will increase for each type of fluid. So we use the sodium in crystalloid minus the sodium in serum over the total body water plus 1. So for example, if you want to use, this patient has severe hyponatremia, he is symptomatic, you would use the hypertonic saline, then 513 is the serum sodium in the crystalloid. The serum sodium is 108, and the total body water, which is usually 0.6 for males and 0.5 for male per multiply kg, plus 1, it is 37.5, which is 10.8 millimole per liter. So each liter of this 3% saline will cause an increase of 10.8 per hour. So you have to know that we cannot increase more than 10 to 12 per 24 hours. So if we divide it into the 24 hours, you have to give this patient 93 milliliters per hour to avoid any complications from treatment of hyponatremia. As we said about the effects of potassium, it will raise the serum sodium. 1 milliequivalent of potassium will increase the serum sodium by 1 milliequivalent. One of the dangerous complications due to sudden treatment of osmotic demyelination syndrome of hyponatremia is osmotic demyelination syndrome or central pontine melanosis, where it can be diffused and only in the pons, and symptoms onset can be delayed for weeks. Cirrhosis will predispose this condition, and hypokalemia is a strong predictor. The causes is rapid correction of hyponatremia. So you have always to stick to the 10 to 12 milliequivalent per liter. Even if you think that this is acute, please stick to the chronic chronic hyponatremia treatment. It is possibly due to disturbance of blood-brain barrier and damage by cytokines, or due to the influx of potassium triggering apoptosis, which is cell death. The presentation is dysarthria, dysphagia, Parkinsonism, catatonia, lethargy, nystagmus. So it is mainly central nervous system presentations. It is usually not really diagnosed by any method. It's only clinical, but MRI might show some changes after a couple of weeks, where there will be white, gray, genital areas, changes in the cerebellar thalamus, subthalamus, potamen, but you cannot really find any specific changes in the brains. But this is an MRI where there are changes in the pontine area, so this is not always specific. And they thought that plasmapheresis might help this condition, but it was found in. So, at the end, tips in treatment of hyponatremia, you have to check all sources of salt administration by other physicians. So please check all the history of IV fluids that is given, or IV fluids given to the patient. Maybe the patient was given dextrose water or half saline, which is very hypotonic to the case and causes hyponatremia. Also check how much potassium has been administered to know how increase in sodium this patient. Monitor the urine output, and in SIDH, any saline fluid used should have a higher osmolarity than of urine. In this case, for example, you have to measure the urine osmolarity before giving any IV fluid for this case. For example, if you do the urine osmolarity and that's 200 in the urine osmolarity, so you have to give an IV fluid that contains sodium more than 200. So if we say, can we give him normal saline? No, we can't, because the sodium in normal saline is 154, but in hypertonic saline it is 513. So you can give him or her hypertonic saline regardless of the if there is CNS symptoms or not. If the urine osmolarity, let's say, have 100, is 100, so you have two choices. You have ringer lactate, because the serum sodium, the sodium in the ringer lactate is 130, and normal saline because it has a 153, 154 sodium. And this is the end of our talk. Thank you very much.
شكرا دكتور. رح نبدأ الأسئلة إذا ممكن. أول سؤال يا دكتور، هل في مجال إن نصلح الكوركشن للصوديوم بميديكيشن يعني بدل الفلويد؟
ما سمعت السؤال، معلش مرة ثانية.
نقدر نصلح كوركشن للهايبوناتريميا other medications rather than fluids؟
هلا the first thing is to what is the volume status of the patient. بالhypovolemia, no, you have to give him fluids. But for example, in patients with hypervolemia, yes, by diuretics, without giving him any IV fluids, you can correct the hypervolemia. The main thing is do not give him oral fluids.
Not to give him orally.
Oral fluids, he should be water restriction. يعني.
طيب يا دكتور، السؤال الثاني، نفترض إن عندنا patient end stage renal disease وجاي بهايبوناتريميا، هل في كوشنز معينة للصوديوم اللي نعطيه الفلويد؟
أيوة.
أعيد السؤال يا دكتور؟
Hello.
أيوة معك.
لا أوكي I heard the question. هلا بالنسبة للpatients end-stage disease that they have hyponatremia, of course giving them fluids will be you have to be very cautious not to put them in volume overload. That's why in the dialysis machine عندنا شغلة بسموها sodium profiling, where we can adjust sodium given to the patient without harming his CNS يعني condition. So we don't really give IV fluids freely in the same patients who are not in dialysis. But the dialysis machine, the new machines which have the sodium profiling, is really helpful in treatment of hyponatremia. بالمناسبة بالنسبة لهذا السؤال, we do not dialyze patients with severe hyponatremia, otherwise they will have what we call disequilibrium syndrome. We wait till the sodium is reached to a safe level. The safe level in such cases is more than 125.
اوكي. طب دكتور لنفترض ان عندنا patient with congestive heart failure، يختلف كمان المانجمنت؟
بالنسبة
مثلا patient with congestive heart failure.
هلا a patient with congestive heart failure fits the or is in the classification of hypervolemia, and so he's having hypervolemic hyponatremia. The hyponatremia, the cause of hyponatremia is water excess. So what is your main goal is to get rid of all this water excess. What is the main issue is giving him diuretics.
ايوه. طب اوكي دكتور، ممكن تلخص لنا ال complications of overcorrected للصوديوم؟
It is only one dangerous complication, which is central pontine melanosis, because it is usually irreversible.
ايوه. هذا أهم شيء، والسيمبتومز تبعها زي ما ذكرت قبل شوي.
Yeah, the symptoms تبعها is usually neurological manifestations. يعني most of the time it ends into death.
اوكي. لسه في أسئلة؟ أعتقد ما عاد في أسئلة كذا. نشكرك دكتور نعيم على وقتك ومجهودك، جزيل الشكر. الله يعطيك العافية. مشكور. مع السلامة.